Dulu ya. Kalau biru udah bisa masuk.
Padat sekali nih.
Panas ya.
Hai.
Ini aktif. Just. Nanti share screen bisa. Iya, bisa. Yang penting backgroundnya nggak usah di tinggal tinggal
sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati untuk ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita
CSI Bangkok.
melayani
Seprofmul.
hati.
Halo. Kamu di sini enggak? Ya, CSI. Coba. Iya.
Karo ada nih sih, ngarepan ya.
Jadi sampai Pak Ketua. Pak Ketua pas lagi mendengarkan.
Ada foto saya sebenarnya.
Coba.
Itu
CSI.
ikon CSI ya.
Ikon, Mbak. Ikon coba.
Oke.
Pelaris dong.
Pelaris.
Bocor.
CSI, Mbak.
Sorry,
Acaranya
bocor.
Asia banget nih.
Pak Risti,
Bocor. Udah belum? Udah.
thank you. Warahmatullahi wabarakatuh. Thank you so much, everyone. This afternoon we will have important meeting with our distinguished guest from Kanagawa Children Medical Center. Our guest today is also from UKK Kardiologi and Prof. Mulyadi also from Cipta Mangunkusumo Hospital. We have performed PDA occlusion this morning. Maybe we can discuss a little bit about our case this morning, Prof. Mulyadi and Dr. Rizky, Dr. Suprahita. After that, we will have one presentation from our guest, Prof. Hidyaki Ueda, about the management of complex congenital heart disease in neonates. I think we have to start now. Maybe Dr. Suprahita will want to explain about the case this morning and what have you learned about new method or new technique. Thank you.
Okay, Dr. Winda, thank you. This morning we proceed the transcatheter closure PDA with the 2.5 millimeters small PDA, and if after we angiography, and patient is 6 years old, girl, and have a weight body weight gaining 4, and then we proceed transcatheter closure PDA with proctorship Professor Hidyaki Ueda, Dr. Rizky Adriansa, and Prof. Mulyadi. We learn much transcatheter closure, and we have learned about the important for the determine the size of device, because we learn from Prof. Hidyaki less than 2 millimeter with the device 6/4, and more than 4 is 8/6. I think maybe Professor Hidyaki Ueda can have some message for us, suggestion for us to patient. Thank you.
Yes. Selamat pagi. Good afternoon, everybody. I'm sorry. Siang. Good afternoon, everybody. My name is Hideaki Ueda from Yokohama, Japan. It's my great honor to join your meetings. And tomorrow, this morning, we had a PDA transcatheter closures with using the 64801 devices. Well, typically, most of them should be straightforward to choose the correct devices because the using the contrast. I prefer to use the AP view of the RLO 20 or 30 degrees. It can show the PDA shape very nicely, and you can measurement using the AP RLO 20 or 30 degrees, and maybe you can use the measurement by the lateral view. But still, in some cases, for example, if the PDA has a Down syndrome and maybe small kids, the PDA will change its shape during the contractions. So in such cases, once you make a selection and then you intended to plant, for example, 8.6 or maybe 10.8, but still during the procedures, the devices might migrated into the PA. That means the devices was a little bit small for closing the PDAs. So in such situations, we should reduce the amount of flow or shunt. So typically, in one of the techniques that you can use it is to cross the PDA with the long sheaths first, and then reduce the shunt flow. Then you will go again for the contrast again. So at that time, maybe you will be able to measurement the true diameters. The formula using the correcting selecting size. For example, if the PD is 4, you just +2, that means 6. So you use it 8.6. But maybe in some cases, 10.8 should be better. So it is difficult maybe in some cases which device is better. So I would like to advise you to do both devices and then look at the contrast, maybe look at the TTE. You will be able that the devices is sticking out or maybe protruding inside to the descending aorta, making the causing significant and also the descending aorta, maybe making something like a coarctation, or maybe the device is too large to maybe blocking the orifice of the left coronary artery, making the significant left PPS. So always I would prefer to evaluate by the TTE simultaneously. And if the device is too short, too large, maybe we could select the one size down. Maybe if the device is too small, if you do the wiggle very softly, if the devices will change or moves, that means the device is too small. We just put one size larger. So I think in a small kids, for especially under years of 2, we should be very carefully to select the correct devices, which may require many kind of procedure. Maybe you have to do size down and maybe size up. But I think the best way is not to hesitate to change the size of the devices among the small kids. Maybe you Piccolo will be works very nicely. So please use the TTE at the same times. That is my advice, especially in the small kids.
Okay, thank you, Prof. Ueda. We learn more from Professor Mulyadi, and we must underline that the TTE, thoracic echocardiography, is most important for the small kid, because we want to evaluate the obstruction of the LPA or aorta. I think it is most important. Learn this morning, and maybe Prof. Mulyadi can have more explanation about the patient.
Okay, thank you. Okay, thank you. I just highlight. I think I agree with Prof. Weda. In my experience, if the patient not too small, like this patient, I prefer choose the seat at number 5. So by number 5, seat number 5, and also catheter picture 5 to make the angiography more clearly, because in PDA we have to see the PDA, the picture from the base until the apex, so we can determine the size. If we cannot see clearly, sometimes miss. It is the cause of the device embolized. So we are better to use the big C's and catheter 5. And then I always make the RAO 30, right axis oblique 30. If the PDA horizontal, so we can see from the right atrial oblique 30. And so far I only evaluate the PDA after closure only by angiography. I never do echo. And I evaluate the echo tomorrow, one day after closure, to make to evaluate there is still sun or there is problem in aortic. Because by angiography we can see if the device obtrude to aorta and obtrude to the LPA. I make the position LAO 60 to make if there is obstruction on the left valve. To make sure the size of the PDA, I also make angiography after the seat cross the aorta, cross the PDA, to make sure that. Okay, thank you.
Thank you. Dr. Rizky, have some suggestions and some comments.
Thank you, Dr. Sufaita, Professor Weda. In this case, I don't not to measure P pressure. Dr. Ika, not measure to P pressure, yeah, because if there is pulmonary hypertension, I will choose to oversize the device. Maybe I will choose 8.6, not 6.4, because I choose to oversize. Yes, maybe. How? What do you think?
To prevent migration.
Yeah.
Yesterday,
Sorry.
yesterday, Dr. Superhider had presented to me to the echo of the TTE. She evaluated the velocity of trans PDA. The maximum velocity was 4.6 or something like that meter per second, which means if the peak velocity is faster than 3.5 to 4.0 meter per second, mean that there's a pressure gradient larger than maybe around 60 millimeter Hz. So that means there is no apparent sign of the pulmonary hypertension. So that's why I convinced that she does not have any pulmonary hypertension. And during my I heard his heart murmur and auscultations. I found that the second sound, the heart sound, was not accentuated. So it was very sound. Does not have any pulmonary hypertension. I agree with you if the patient have a hypertension. For example, if the patient have about 5 or 6 millimeters PDA, usually the majority, maybe 1/2 or so, may have a borderline pulmonary hypertension. So at some case, I think that your point is correct. If the PDA size is a little bit large, I would like to prefer to use the oversize. Yeah, and also the comment of the Mulyadi. The Mulyadi had pointed out very, I think, important things, because in the other case, if you have a residual shunt among the devices, even very small shunt, in some cases the hemolysis will soon happen because of the residual shunt. So in the adult, the residual shunt should not be allowed. It's not acceptable. So the body size is large, and even the ampulla size is large compared to the small children. So I agree with him that the larger size which works better. But in the small kids, the PDA is very soft tissues. So when you put the ADO, maybe you can detect very small amount of the residual, but most of them will be disappeared for about within 40 hours. But still, if you hear the heart sound, or if the residual will reach to the pulmonary valve, maybe the peak velocity is very high, so residual maybe reach to the pulmonary valve. In such a significant shunt, we should not implant that devices. It should be one size. We should use one size large ADO. But this morning, there was a smoky leakage from the middle of the devices. If the leakage is smoky, that is acceptable, because within maybe a few hours, the resistance will be disappeared, and we could not hear any kind of the heart murmur. I believe when she reached to her room of the Lord, I think the heart murmur was not audible.
Okay, thank you, Prof. Weda. Maybe I will explain that. We proceed the echocardiography transthoracal before the transcatheter closure yesterday, and we measure the velocity of the PDA, and I learned about the velocity more than 3.5 or 4 is likely for pulmonary hypertension. So this morning I learned about Mr. Hideaki Ueda directly to PDA from RV to PA. So not we measure the PA. I think before we do transthoracal echocardiography. Okay, thank you for my teacher, Prof. Hideaki Ueda, Prof. Mulyadi and Dr. Rizky. I think this morning we learned much from all of you, and thank you very much supporting me to proceed the transcatheter closure. Last week we do with Dr. Hasri Samyon from IGN. We do transcatheter closure of PSD and PDA, and now, this morning we do just one case because another case is Weaver. I think this discussion enough maybe directly to management and complex congenital heart disease. Dr. Winda will be next moderator. Thank you.
Thank you so much to all facilitators, our professors, our colleagues. We hope that we can have collaboration between Indonesia and Kanagawa. Okay, we will proceed to the guest lecture. Today we will have a presentation from Professor Hideaki Ueda about management of complex congenital heart disease in neonates. So time is yours.
This is complete. Beda ini yang terus. Itu udah belum. Oke. Ini siapa? Ini saya. Oh, layar aku. Ya, oke. Oke, we'll start.
Okay.
Thank you, everyone. Thank you to attending to my talks. Yesterday, I was focused on the treating to the PDA and treating for the ASD and how we could do for the PDA stenting. Today, I would like to focus majorly among the management of the complex congenital heart disease in neonates. Next slide, please. As I recommend, just was 2018, the it's okay.
Oke, udah. Oke.
Oh,
Zoom-nya udah. Coba coba. Oke, oke, yes. Oke. Ya,
okay.
oke.
So I would like to talk again. It was 2018. Dr. Winda, Irfan, and Wang and Nico had visited to our institutions. This was about 5 years ago. And then the pictures here, Irfan, Aziz, Wang here, Nico here. And we had a very nice talks. And I would like to introduce where the Yokohama is. The dot means the population of the people in Japan. And the
Sorry. Hah? Ya, sebelah. Oh, mirip kan? Pokoknya udah aku bilang mirip tuh. Bisa. Oke. Udah benar. Bisa. Oke.
Okay.
Sorry.
Oh, it's okay. So I just go back. My institution's name is Kanagawa Children Medical Centers, which means the Kanagawa is located just southern part of the Tokyo. It's next to the Tokyo. And we have about 8 million people in Kanagawa. And the capital is Yokohama here. And the middle, our institution located around here. This is a picture of our hospitals. And we have a totally 430 beds. It is a second place in our countries. And we have a ICU 10 beds. NICU has 21 beds. Post-NICU has 23 beds. And I would like to recommend to visit our places because at the beginning of April, we will have a very beautiful cherry blossoms. And so I would like to talk about the stage approach for single ventricle heart. Well, the most important things of the controlling the illness, we have to determine that which hemodynamics, for example, univentricle heart or maybe biventricle circulations is adapted for the kids. And then once we decided to move on to the univentricle system, we have to prepare for those kind of the stage operation. For example, we have to prepare for the BCPS, bicavernal pulmonary shunts. I would like to talk later about 3 to 6 months. And after the fountain circulations are for the age of 1 to 1.5 years. This is the annual numbers of the fountain operation in Japan. Annually, we have about 300 to 400 cases among the whole countries. And what is the numbers is the fountain in our institutions? Just before 2004, Dr. Russell was not working at these places. We have a very small numbers of doing the fountain. But after when the Dr. Russell reached to our places, the numbers of the cases have grew dramatically. Maximum had reached numbers of 30 cases. And what had changed the age of the fountain operation? Previously, approaching for the AP fountain was just around maybe 4 to 8, but still using the stage operation, it had dropped to maybe 1 to 2 years old. So that is a very big changes. And what happened in the surgical mortality is previously the fountain operation had a mortality up to 24%, but right now it is just below to 0.7%. So most of them could survive after fountain operation. Well, there is some complicated heart disease such as the Asperger's syndrome. I have presented the 1990 to 2004, there was a 57 cases, and we had classified in two groups. One is the higher, has a poor. So using this kind of the classification, we can see that even such a complicated heart disease, the patient could survive a much return abnormalities, or maybe have a massive valve, every valve regurgitation, maybe a pulmonary valve obstruction, pulmonary vein obstruction. The prognosis is poor, just below the 0.2. So that is a still big issue, even for us. So here, as you can see, that the most severe cases in this area, we have to do something about this one. But still, the other cases which has no risk factors, we are very delighted. We are very glad. So I would like to talk about what is coming up about the HLHS. Among the previously, just the beginning when the Dr. Asu had arrived, we have began to perform node operation first, but still the survival ratio was just only 0.5, which means that half of them would die. So we wanted to improve these numbers. So then we move on to the first of all, we did for the bilateral PA banding first, and then move on to the node shunts, the modified node operation. But still the number didn't improve so much. We were not pleased with these numbers. So we decided to move on to change the strategy. Recently we have adopted the treatment as first we performed the bilateral PA banding first, and maybe put the PDA stent in, or maybe to let them continuous infusions of the prostaglandin. And then at the age of 3 months or 4 months, we move on to the Glenn shunts. Such patient will be survive much more than 80%, and the number is now right now is acceptable. So we would like to perform adopting this kind of the strategies. So this is the schema of the PA banding. I think this PA banding is very critical and very important for me. Well, this is a picture of the PDA using the, we have to tapering among the main PA here, and then we make a notch around here to make a restricted place inside the pulmonary arteries. This is the picture of the bilateral PA banding. We have to do the PA banding in the right pulmonary arteries and then left pulmonary arteries. But still, those diameter of the pulmonary artery is not so large, maybe up to maybe 4 to 6 millimeters. So PA banding is very difficult to do in the small chamber of the vessels. So that is a very great issue. It requires adequate knowledge and adequate techniques to make efficient, good banding among here. So this is the formula which we use it for the PA banding. As a transfer, there's a formula, and we used to do much more tighter. So I think the number we had done is using the formula of the body weight plus 16 or maybe to 18. So this is a very tight one. If you looking at the echo, the only shunt maybe did measurement such as maybe 2 millimeters or so. If you found the shunt between the banding is wider than 3 millimeters, which means that we're not satisfied with the view because the banding is not so tight enough. So we always ask the surgeon to do much more tighter. So if we saw the color flow maybe around 2 millimeters, we were satisfied and then let them go. So the echoes is very important, and we cannot do echoes. So during the operation, we always ask you to perform the echo to see whether the PA banding is working or is not. So I would like to focus about the PA banding. I think that is the most important thing to control the complex heart disease. What is the purpose of the PA banding? It's of course the most reason is that to reduce pulmonary artery flow, to reduce the volume overload against this only one systemic chamber. So as you know, maybe the patient had only right ventricle, which means that they could not bear the volume overload. They maybe get suffering from the congenital heart failure. We should perform the pulmonary bonding very fastly. And also, there's another important need. That means that if you let them, if you delay the PA binding, what will happen? That the binding will protects the peripheral pulmonary vascular bed damage by lowering the pulmonary artery pressures. If you delay the pulmonary artery bonding, vascular obstructions (PVO) would occur inside the pulmonary vessels, and you cannot proceed for the Glenn shunts because of the high PA resistance. We have to drop the resistance first and then move on to the Glenn shunts. So we want to get the pulmonary artery in good conditions. That's why we wanted to decrease the pulmonary artery pressure first to let them maintain the vascular bed for this complex heart disease. Then I think this is the most important purpose for us. So I would like to say that these excessive pulmonary blood flow, which mean that the patient will suffer from the pulmonary arterial hypertension, will lead always damage of the pulmonary vascular bed, which cause the pulmonary vascular resistance (RP), and then makes the out of indications of the Glenn shunts. Even you perform the Glenn shunts among these high resistance pulmonary arteries, the Glenn shunt would not able to get through. The pulmonary flow will not maintain because of the very high resistance of the pulmonary arteries. So preparing for the PA banding, we always look for the saturations. If the saturations will go up or higher than the 90%, which means that QPQS should be around maybe about to 2.5 to 3. So this numbers is so high. So when we found that the patient will have above 90%, we just want to reduce the QPQS fastly. But there's still a very limited treatment. Most easiest way to drop the QPQS, the pulmonary artery flow, is to use the nitrogen gas, which means that we call them hypoxic therapy, which means that we use the oxygen's concentration drop, because almost in the atmosphere it will contains air. Oxygen is 20.8%, nearly to 21%. We just a mixture of air plus nitrogen gas to reduce the oxygen's concentrations just around maybe 17 to 18. If the saturation is still high, we just add much more nitrogen gas, minimum 13%. So if you want to make the 13% gas, for example, if you use the air for 2 liters per minute, and then let them nitrogen gas plus 1 liter per minute, the oxygen concentration will be 14%. So it's a very easy and it's very efficient way to reduce the excessive pulmonary blood flow. here there's a simulations of using the univariate circulations. As you can see, if there's a 2 amount of the cut is there's a high output. This is low output. The QPQS is, for example, is around 1. The saturation here is the saturation. Here there's the O2 delivery. And you can see that the saturation around maybe certain percentage will be near to the QPQS 1, which means that the O2 delivery will be reached to the maximum level. But once the saturation will go to the 80 to 90 percentage, that means the QPQS will move on very increasing. And what is the most important thing that O2 delivery would drop dramatically. You know, the kids should be get very sick. You know, when the saturation is around maybe 90%. So this is the number which we like to talk about. I would like to ask you to remember that the ideal saturation should be around maybe 75 to around maybe 80 or so. So if you found the saturation is above the 85 to 90%, I would like to recommend to use the nitrogen gas. So this is another pictures of the using the same simulations here. That if the QPQS is 3, the O2 delivery will drop very fastly. You know, if the saturation is just above maybe 70% or so, the O2 delivery will be well maintained. But still, if the saturation will reach to 90%, something like QPQS 3, the O2 delivery will be dropped. So the circulation will be not maintained anymore. So I would like to express again that our target saturation is just about 95 to 80%. So what is the best way to check it by the blood gas analysis BGA to be sure that the PaO2 is just below to 45 millimeter mercury. If you found that the PaO2 is just above 50 or so, I think we should start the nitrogen gas to reduce the PaO2. And then we should monitoring the urine output continuously, because I think the maintaining the 3 to 4 millimeter per kilogram per hour is very important, because if the urine output would drop, that means that the systemic circulation had decreased because of the excessive pulmonary artery flow. So if you found that there is a very high flow status, for example, the saturation is above the 90%, maybe we use the nitrogen gas. There is another option by using the controlled mechanical ventilations to reduce the respiratory rates using the muscle relaxant drugs, because we want to make these PaO2 retentions up to maybe 40 to 50, but still not becoming below to pH 7.4. So in such cases, we'll repeat the BGA very carefully to be sure that the pH will be maintained around maybe 3.5 to 7.35 to 7.4. And still the target value of the PaO2 will be just below the 40, and this PaCO2 should be 40 to 50. And after that, as you know, that soon after birth, the physiological pulmonary vascular resistance should be very high, but it will begin to decrease in a few days. So the resistance, the high resistance status will change to the low resistance status. So once you start maybe hypoxia therapy, or maybe you start the conventionals, if you found that the resistance of the pulmonary artery will get normalized, we should tell to the surgery that please do it for the operation. It's ready for the operation. So in such cases, in our institution, we just tell them, the surgeon, to move on to the permanent bonding. And then the permanent bonding will be performed within the 24 to 40 hours. So if the patient is HLSS cases, during the bilateral PA bonding, we just move. There are two options. Maybe we induce the drug infusion continuously using the prostaglandin, or maybe we use the PDA stenting. There are two options, but still the bilateral PA bonding is critical to perform in this critical phase. So this is another image that I would like to show that that means that the balance of the pulmonary resistance, and also you have to think about the system of circulation is very important, because if you want to let the RP drop, it means that the QP will be increased. That means that it will decrease the systemic circulation, so QS will be dropped. So that means the QP/QS will be dramatically improving. So reducing the resistance of the pulmonary artery may cause a very excessive QP/QS changes. So you should be very carefully to do so. So even for inducing the oxygens, I would like to cause the great attentions about the QP/QS. What happened to the QP/QS? So there's several options to let them reduce the RP. Maybe you can use the oxygen. Maybe you can nitrogen oxide gas. Maybe you can use the prostaglandin. Maybe you can the milrinone, alpinone. Maybe you can the pH drugs. For example, maybe you can use the PDA5 inhibitors. Maybe you can do the endothelin receptor blocker antagonists. Maybe you can use the prostaglandin. So there are some kind of the options here. But instead of the reducing the RP, if you want to let them, decrease the pulmonary artery flow, there are not so many kind of options. As I have mentioned before, just only the nitrogen gas and the mechanical ventilations to let them maybe hypocarbonate PaCO2 increasing. Maybe you can use the high P, maybe up to 5 to 7. Maybe you can use the 10 millimeter mercuries to let them PaCO2 retentions. But still, as you mentioned, that there is no effective drug exists which will available to use it. So that is why the PA bonding is the only option to save the life of this critical ill. So whenever you start the nitrogen gas, the PA bonding is just to be combined with this kind of therapy. So never do the separately, because only the PA bonding can save the life of these kids. So I would like to show the picture of how we performed in high hypoxia therapy. We just this is the yellow is the air tube. We put the maybe 2 liters per minute, and then the other maybe I think the green tube from maybe from the nitrogen gas pump. I'm sorry, maybe 1, and then mixture of maybe air 2 liters and nitrogen gas 1 liter, which means that it was the drop to the oxygen up to maybe 14% or so. But just only maybe 0.5 liter per minute maybe works very well, because the oxygen of the concentration will drop to maybe 17 to 18%, will be good enough for maintaining the saturation around the 75 to 80%. But still, you have to be very carefully that the acidosis will not happen in such treatment. So please repeat the BGA to be sure that there is acidosis inside will happen. And this is the nitrogen gas connected to the respiratory system. So using the nitrogen gas, what will happen? The saturation will be dropped soon after, maybe 5 to 10 minutes or so. It will get very, you can see the efficacy of the nitrogen gas, how it works. It works so well or not. You can decide it to put the increase the nitrogen gas amount. Maybe you can increase, maybe if the saturation is too high for you, you put the larger amount. If you found that the saturation can drop dramatically, maybe just below the 90%, 70%, you just decrease the amount of the nitrogen gas. It should be very easy to control it. And what happened to the respiratory rates? You can see that the respiratory rates will be dropped within 30 minutes or so, which means that the patient will get very stable, and the heart failure will be get increased. Heart failure will get decreased. It's very easy to determine whether the nitrogen gas is doing well or not. Looking at the respiratory rate, maybe you can see the urine output will be increasing in such inducing those kind of the treatment. And the most important thing that nitrogen gas is well used, as you know, in the racing car, the natural gas is well used for it. So commercial base is not so expensive one compared to the nitrogen oxide. It should be maybe in Japan only 1/3 of the total cost. So I think the nitrogen gas should work very nicely. So I would like to recommend to induce such kind of the therapies. Well, this is pictures of the schema of the patient who had received the BT shunts. I think you will be able to think about it. If the patient had an 80%, if the SOEC saturation and IVC saturation is just near to the 60%, it will enter to the central ventricle, and then from the pulmonary vein, it will come here inside to the same chamber. So always the pulmonary vein saturation should be around 80% or 100%, and then it means that it will drop to 80%, right? So the 80% blood flow will enter again to the pulmonary arteries, which means that the cardiac output should be QP plus and QS. And if the saturation is 80%, you can calculate that you found that the saturation is 80%, QP QS should be 1. That means the cardiac output is double of the QS. But once the patient had reached Glenn shunts, something will happen different. From the same kind of the formula you use it, you found that the saturation is only 80%, but the QPQS will drop to 1/2, which means that cardiac output is near to QS, which means that the workload against the single ventricle will be dropped to 1/2. Here you can see the cardiac output is double of the QS. And once the patient reaches to the Glenn shunt, it will reduce to only the single QS. So our management of the congestive heart failure, the most strong treatment is to convert to the BT shunt to the Glenn shunt. So whenever we see the suffering with very severe congestive heart failure, we always think about when we should proceed to go to the Glenn shunts. Once the patient will achieve the Glenn shunt, the workload will be reduced to 1/2. So that's why we always think about the Glenn shunt, but still to maintain the pulmonary artery circulation only by the Glenn shunt, it has to be very low pulmonary resistance, just below to 2.5 resistance widths. So if you found that during the catheterizations and the evaluation, if the Glenn artery is above 3, we will not perform the Glenn shunts. We have to put on the pH drug first. Maybe we have to put the O2 oxygen gas to reduce the resistance pulmonary arteries first. And then when we found that the resistance will normalize just around maybe below to 2.0 to 2.5 widths, then we will move on to the Glenn shunts. So please remember that the Glenn shunt is the most strongest therapy for the congenital heart disease who are suffering from the congestive heart failure. So my conclusion is that the most important points of the management of the complex congenital heart disease in neonates is to keep balance of the pulmonary resistance and the systemic circulation. We cannot divide it, you know, always if you mean that if there's if the pulmonary resistance will drop, that means the pulmonary artery flow will increase, which means that it will cause the very low systemic circulations. So we have to be very careful. And also in treating in such situation, the hypoxic therapy using the nitrogen gas, maybe the mechanical ventilations, we can able to save lives of the critical ill children. So the target of the hypoxic concentration should be around 13 to 19% mixed air, and then we should always think about when we should perform the PA banding operation. But I would like to recommend to induce this operation, PA banding, within 24 to 40 hours later when you induce to nitrogen gas or maybe the mechanical ventilations. Okay, this is the end of my slide, and I hope that the controlling the complex heart disease is very critical, because you always have to think about pulmonary resistance and the systemic circulations. Thank you for your attention. Thank you.
Thank you, Prof. Weda. Yes, I think maybe we are really thank you so much for your excellent presentation. We will have a discussion after this. Maybe we need to raise question. I think we can have raise question from the audience here. Maybe I want to ask a question.
Yes.
Yes, preparing the bilateral PA banding in hypoplastic right heart syndrome case. Could you please explain to us from your experience in your institution, and how that you manage the multidisciplinary group even before the baby born, prenatal diagnostic with fetal echo, until you manage the newborn and decide to perform bilateral PA.
Thank you very much, and I think you had done a very important question, because that is the most important purpose for getting diagnosis during the fetal, because once you found the HLHS during the fetal, you have to explain about your plan, how you would like to perform the operation, how you would like to management for the parents. And soon after birth, you check it by the echo and start your strategy, right? And most of the cases within the hemodynamics will be changed dramatically very fast. So whenever we do the conference meetings, short conference meetings in the morning, then we decide we will do the PA banding or not. If I found that the patient is stable, we just keep observation. But still, when we found the saturation have reached to the level of 90%, maybe at that time we start to nitrogen gas. And then at the evening meeting, we tell them to the surgeon that we have started to nitrogen gas. That means that the pulmonary artery pressures or maybe resistance of the pulmonary arteries had changed. Maybe it's time to move on to the pulmonary binding. So due to those kind of information, we'll decide when we should perform the PA banding. So I think we just decide the timing of the banding twice in a day. So every day we'll just have a short meeting to be sure that this is not the good time. Because once you lose the time, maybe the baby will suffer very congested heart failure. So we have to be very carefully. Well, I believe the most easiest way to evaluate the heart failure status should be urine output, because majority of the heart failure cases should get, the urine output will drop maybe around 1 cc per kilogram per hour. So at that time, we tell them to the surgeon that we should do something rush. So if you found that once you started to nitrogen gas and the urine output will not maintain a good level, we just send the patient to the operation room.
Thank you. So in this hypoplastic hypertension newborn, we actually can prepare before the baby. We must tell the pediatric cardiac surgeon to get ready once the newborn. But I want to know about we still don't have the nitrogen gas. So
Every person should use it.
Every person should use it.
Because you have many racing cars, right?
Okay.
Because racing car, maybe sports car, maybe use the nitrogen gas because the tire will get good form. So I think it's not so difficult to get purchased the nitrogen gas, because the commercial base they will use many nitrogen gas. It should be very cheap.
Yes, maybe we need to learn how to administer and to mix the nitrogen gas with the air.
But it's very easy. It's very easy because you have to use only two. One is for air, one is for nitrogen gas, and then let them mixtures, combine them, and then it will get only one output. So you will have a oxygen when you drop. Very easy. You can imagine it. One is for air.
Yeah, you
Yeah,
have to.
yeah, it's very easy. So when I started to nitrogen gas, I was make a list of the nitrogen gas, asking to the nurse if the saturation would go up please increase the nitrogen gas 0.1. If you found that the nitrogen gas is not doing well, increase another 0.1. So they're looking at themselves, they'll change the amount of the nitrogen gas. So you don't have to be in the same place. Yeah.
Calendars.
Yeah. So only looking at the saturation, and the nose can change the amount of gas.
Please explain about and please explain about the particular group of hypoplastic left heart syndrome baby which have restrictive intra ventricular.
That's another important issue, because once you found that the restrictive pulmonary value will get very narrow, the maybe congestive pulmonary flow will be happen. But still, in such cases, the saturation will drop, and then heart failure maybe decrease, maybe, because the QP QS will drop. So once you dilate the restricted PFO, soon after the saturation will be grows very fast. So you have to prepare for the PA boundary. So whenever you do for the best or something like that, you always think about we should perform when we should perform the PA boundary. So we always think about whenever we do the best, we always tell the surgeon, today we will perform to the best. So maybe tomorrow we would like to ask you to prepare that. So the hemodynamics will change very fast. And it's very difficult to predict whether the saturation will get stable or not. The majority, it will drop very fast. So in several cases, we do in the morning best, and then we move to the operation in the afternoon. It depends on the saturation levels.
How about the baby?
PDA is good because once you let the PDA widely open, by implanting the stent, this body circulation, system circulation will get very increased, which means that heart failure will get very easily controlled, right? So stent implantation works very well against those congestive heart failure. But still, during the procedures of the stent implantation in the very small kids, younger than 1 month, maybe 2 weeks or so, if you proceed the guide wire, maybe long sheets against the main PA, the wire will block the normal heart contractions, which means that during those procedures, the blood pressure will be dropped very easily. So in such situation, I would like to recommend to do in the hybrid, because during the hybrid should be the whole procedures does not require so long. You can do it very fast when you get in good experience. I think those procedures, inserting the wire and then the stent, should be finished in maybe 15 or 30 minutes. But once you do for PFO, the femoral vein, I think it will take maybe 30 to 1 hour or so. But still, the hemodynamics will be frequently change. And anesthesia, doctor anesthesia should be very frightened, because the blood pressure will drop so fast and they will maintain very low levels.
Thank you, Dr. Linda. I asked, PA bending mean is a bilateral PA bending. So maybe you can tell us about proceed the PI bending because different bilateral PI bending and PI bending. So maybe this next advanced procedure, hybrid procedure in congenital heart disease.
It's very hard to explain because this is the most important things. Well, if you do the banding, you have to open the chest, right? And then you will do from the on this, you put on the heart, and then you can measurement the velocity of the bending, and see whether there is shunt, color shunt should be around maybe 1 millimeter or so. If it's larger than 2 millimeters, that means the banding is not working well. So during the surgery, we will just scrubbing, and then we just do the scrub equals among the chest. Incisions, and put on the heart, and then we will start the evaluation and see how the color flow will happen. If we found that the banding, the area of the banding color flow wide than 2 millimeters, we ask them to put one incision to let the banding much more tighter. And if you do too much, the saturation will get dropped, right? So in doing the bilateral banding, we do not let them chest close. The patient will move to the ICU in the open heart conditions. And then when you found that the saturation is getting dropped in or maybe get increasing in the ICU, the surgeon will do put the another incisions against the banding, or maybe let them release the banding. So all the chest should be get open to how to say, very easy approach will be able to this.
In ICU and the procedure is in ICU or back to the.
Well, it depends on the circumstances. If you have to do in emergency, you can do it in the ICU. But if you have a time, maybe you can let that baby into the operation. Do that. But still, I believe in the ICU should.
Okay, thank you. This is so much. We have done assignment. 2 cases, and both died. And then after we discussed with the we should do don't do normal drugs. We should do bilateral wedding and this. Then the child began, we plan to do normal.
Yeah. And that's the correct way.
Yeah. And just one small person, sometimes the surgeon always ask about that, about the importance of oxygen test in complex and how it took place. Sometimes are confused. Dr. Yusuf always said about that. Oxygen test in complex coronary disease. What important and what is the interest? Thank you.
Oxygen
Complex disease.
oxygen tank we do measurement of for flow ratio and resistance, and before oxygen, and after 10 minutes oxygen 100%, and we do again the flow ratio and resistance.
I see. Well, I think you have pointed out very important things, because if you have a very high pulmonary artery resistance, we have to insert, you have to start 100% oxygen, for example, 5 minutes and 10 minutes, and evaluate again the resistance of pulmonary artery, whether it will drop or not. This means that it is active, non-reactive. If the cases of non-reactive, we cannot proceed with any kind of the operation. But as today I will have focus on only for the small case. We cannot perform the oxygen test, because once you put the oxygen test, it may get arose so fast, it may, it may change these conditions very quickly. So it should be very, maybe in some cases, very dangerous. I have misdiagnosis of the HLS cases of the bilateral pneumonia, because the patient was had a massive valve, AV valve regurgitation, and showed a very low saturations, around maybe 70, maybe 72%. And so I decided to put the oxygens. And then I started the oxygens, and I have to do the blood test. And once I put the needle inside the vessels, the baby had begun to cry, and only one cry or two cry, the heart arrest had become. Because as you mentioned, that the mixed venous SVO2 will be dropped because caused by the severe congestive heart failure. As you know, if the heart failure will get worse, the SVO2 will be dropped, right? The output is not good enough to maintain the saturation. So in such situations, once you put the oxygen, you drop the resistance, and then baby will suffer much more. So in such cases, you have to put the, how to say, catecholamine, maybe dosmin, maybe dobutamine, instead of the oxygen. So once you have to determine whether the desaturation is caused by the decreased pulmonary outflow, maybe it will have caused by the low output. By looking at the echo. If the heartbeat is weak, we have to proceed putting substance activated heartbeat first. But when you found out the low pulmonary flow, then we should put the oxygen. But still, we have to be very careful to determine whether the oxygen is good or not.
Yeah, I want to ask you about the perspective. Apa pasti because we want to start to we want to know what the respect like we body weight.
Well, whenever we see the ascending outflow is now 2 millimeters, that is our highest risk, because the coronary artery flow will be decreased due to the very small changes of the systemic circulations. The ascending aorta means that the coronary artery's resistance should be very high, right? So whenever you see the ascending outer diameters, it's just narrow the 2 millimeters. We should be very careful to control first. And then if the body size is lower than 2.5, it's also difficult to keep management. And I think the third thing is that the amount of the tricuspid valve regurgitations. If once you see the tricuspid valve regurgitation TR is much more than moderate, it should be very difficult to get supply. So in such situations, we should proceed, to get lower level of the pulmonary artery as possible. We just put the nitrogen gas to drop the saturation around maybe 70%, 70 or 72, which is acceptable pH. Maybe we just want to drop between 7.3, maybe just below the 7.35, lower than the other HLSS cases. TR is very most how to say important time is if it's moderate and more than moderate, it should be very difficult. If the patient is lower than 2.5 kilogram, it's also a very good disease. And the most important thing is the ascending out the diameters. If it is below 2, it should be very best. Yeah.
So, if the hypoplastic left syndrome and only foramen ovale, persistent foramen, you perform balloon atrial septostomy. What's the ideal timing? You perform PDS stents and PABN stents plus balloon atrial septostomy, or only balloon atrial septostomy. Next to time, you perform the hybrid procedure. What do you?
Thank you for a good question. The purpose of the death is to reduce of the pulmonary artery resistance. So we want to be sure that once the resistance has dropped, then we go further for the bilateral banding. So I think we don't perform in the same times. So if you found that the PFO is getting restricted, maybe you do the best. But in some cases, the best does not work so well, right? Because Dr. Winder can understand, because the atrial septum is some cases getting like a tentacle muscle, right? Around maybe thicker than 4 or 5, the best does not work so well. So whenever you see the atrial wall is very thick, you have to implant the stent. But even for the stent implantation, it's not so difficult, because looking at the echo, you put it over the heart, right? Imagine that you put the echo on the heart, and then looking at you insert these sheets needles, a very long needles, about the connection of the IVC and the RA to get the distance. And then you looking at the echo, you just proceed the needle and then perforate for the atrial wall, and then you proceed the guide wire. Then you can get across maybe a small amount of stent, maybe 5 or 6 millimeters diameter stents should work very well. And those procedures are not so difficult. But once you implant the stent, if the procedures works very well, the saturation where we get the most, right? So you found that the saturation is getting increased. That means that we should proceed with the pilot feedback. And at that time, you should do the pilot feedback, and then at the same time, so you practice and bound with people.
Yes, because we already have prenatal diagnosis, so we have more referral case of hepatitis. Even we already have one mom, pregnant mother, came to our fetal heart clinic, and she said, "Dr. Winda, I remember the first children is that my first baby is also hypoplastic heart syndrome, and when I did the fetal echo, and the second is also hypoplastic."
Wow.
That's why
Oh.
I think maybe from Riyadi, we must have a particular team to manage hypoplastic heart syndrome, big Kanagawa together with the and also our pediatric areas. And now, yeah, before maybe I don't know. In
But-
1 year, how many?
Yeah, it seems to me that you have much more number than us, so I think it should be better. So this is your first advice. So. Yes.
How many cases?
Well, in a year, about maybe 5 to 10, but actually, what is now happening in Japan, even the patients who parents who have HLS cases,
Yeah.
they began to refuse to get treated. They tell us that please do not treat HLS anymore. Yeah. So, well, there's a very sad story. Actually, because I think that, to be honest, in our institutions, among these 5 or 7 years, I don't see any critical AS, coronary artery actuation, or the PAVs, which is a good candidate for the perforated coronary vein, coronary valve. And I just about 5 or 6 years, I do the coronary valve synthesis for around maybe 4 or 5 cases for each year. And then I perform many cases of quick bypass. As recently, these 5 years, I never see. So
Yes, maybe because we already signed an MOU from with Kanagawa to the representatives. My medical director from Japan, now in Japan, already signed Kanagawa, the representative for memorandum of understanding. So maybe, so it will make us easier to have a special project with you. And if you want, if you have a hypoplastic heart prenatal diagnostic, you can tell.
yeah, yeah. You can send the images to me so that I can tell you what we should do.
Alright. Okay, thank you for your explanation, and thank you to all the participants in Zoom and also in this room. We hope that we can have a good collaboration, and not only at RSAWR Hospital, but also from other hospitals. They have Terusky is the head of pediatric cardiology working group in Indonesia. We have around 70, how many? 75 pediatric cardiologists.
Now 61.
61 pediatric cardiologists in the whole country. All right, I think we come to the end of this event, and also from yesterday we already have a presentation, and I think we can upload in YouTube RKB YouTube channel. Thank you so much, Prof. Hidayat. We hope to see you again, and whether in Zoom or in we go to Kanagawa.
Maybe I can.
Oh, you come here again. Okay. Thank you, everyone. Good afternoon. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much. Thank you.
Yeah. Yeah.